Hi everyone, welcome back to our 87th journal club. Just kidding, I don't know how many we've done, but we've done a lot. I feel like we've done a lot, and we have about one more month left of articles on Mondays and Wednesday nights at 7:30. We did have to cancel last Wednesday because Facebook was down for like, I don't know, at least 8 hours. Um, and I think by the time it came up, I didn't realize, but and that's never happened before, but there it is. Okay, so tonight we have Dr. Rebecca Hendrickson, and I'm just waiting for her to join us. I'm gonna try and tag her. She is presenting an article on Prazosin and PTSD. Sorry, let me just add her. Okay. And see if we can get her onto the video. So yeah, we're just waiting, and she's in a different time zone than me. So I'm in Central, and she's in Washington State, so that's Pacific time zone. So she has been like very gracious to offer up her time. She seems really busy, but she's kind of an expert, I would say, in her field, which is PTSD, TBI. Yeah. How's everybody? Is anybody watching? I don't know why she hasn't added herself. Let me see. Okay. I think she's trying to text me. Okay. Okay. Hey guys, for anybody watching, welcome back. I am waiting for our guest. You know, we practice these videos, I promise, but sometimes there's just these technical issues. So I'm just waiting for Dr. Hendrickson to join us. In the meantime, I am kind of caught up on messages. I always feel like I'm a little bit behind, but I'll work on that a little bit after we finish the video tonight. So if you're waiting to hear from me about something, wait no more. Okay, so, there's Dr. Hendrickson. Hi there.
Hello.
Hi, how are you?
Good, how are you?
Good, thanks for joining us. I was just chatting with myself in the group. Okay, so
Excellent.
so I was just saying that you are very busy, and you're at the University of Washington in Seattle?
Yes.
No, that's where okay, so let me read Dr. Hendrickson's bio, because she seems very accomplished, and this is like really worth a read. Okay, so Dr. Hendrickson attended the University of Washington in Seattle for her bachelor's and then completed her MD, PhD at Washington University in St. Louis, and her PhD was in neuroscience. She then returned to the University of Washington in Seattle for residency, followed by a 3-year research fellowship at the Seattle VA. And that was in mental illness research, education, and clinical center. So currently, she spends 25% of her time at the Seattle VA as an attending physician in the PTSD outpatient specialty clinic, and then 75% of her time as a research investigator in the MIRIC, which is that mental illness research, education, and clinical center. And she has a faculty appointment through the University of Washington. So it looks like her research is on a lot of kind of complex things, but related primarily, it looks like, to traumatic stress or TBI and sleep. And maybe she can chat about that a little bit more. And she has been an active member in Psychiatry Network. I always look forward to, I know her as the PTSD psychiatrist, so I know I consider her an expert in her field, in her specific area of psychiatry. So thank you so much for agreeing to do this article. and or maybe you volunteered, I'm not sure, but thank you. And yeah, take it away. I didn't even say the title of it, so feel free to
Oh, yeah, yeah.
start from the
And can you
beginning.
hear okay? Is this loud enough or?
Hmm. I think
Okay.
so.
Yeah, so I'm presenting the New England Journal 2018 paper called Trial of Prazosin for Post-Traumatic Stress Disorder in Military Veterans, um, which is fundamentally, it's a multi-site randomized controlled trial of Prazosin for PTSD. And I was going to do it, apologies, in slightly a different order, perhaps, than what we've often done, um, because I think it might make it more coherent of a story. So I was going to talk about what the sort of trajectory of this research has been very briefly, why
Okay,
this paper was done,
sure.
um, and then what the basic findings of the paper were.
Hmm.
And then I think that'll make it obvious what the big questions are. And when we go through like the specifics of the paper, we'll have a good framework for what are the main questions we want to be asking of these specifics. What's the questions people are digging into the paper for? So a lot of people probably know the story of Prazosin. So in the 1990s, PTSD was sort of seen as a chronic, debilitating disorder for which there were very few effective treatments. And recurring replicative trauma nightmares were one of the hallmarks of this. And I actually remember this era. I grew up the daughter of a social worker, and she worked with a lot of refugee communities. And so I remember volunteering in her groups from a pretty young age and just saying over and over and over again the sort of debilitating nature of these symptoms. And we just had so little that we could do. Um, and so um, Dr. Raskin, Murray Raskin at the Seattle VA, was actually trained as a geriatric psychiatrist. And he and Elaine Peskin, also geriatric psychiatrist, both studied the role of noradrenaline signaling in Alzheimer's disease. But as things go at medical centers, for various logistical and political reasons, at some point, Dr. Raskin was asked to help facilitate a group for African American combat veterans from the Vietnam era with severe combat-related PTSD, which was not his wheelhouse as a geriatric psychiatrist. But once he started working with the members of this group, he became very focused on how closely tied their nightmare symptoms, especially, seemed to be to the symptoms of increased noradrenaline signaling, which he studied in Alzheimer's disease. And so, sort of out of desperation to find some way to treat these nightmares, many of these people have been having them for decades, often every night, several times a night. He started trying antagonists of the noradrenaline receptors. He first tried propranolol, and which is a beta adrenergic receptor blocker, and nightmares got worse. So he thought, often there's two receptors, and if you block the wrong one, things get worse. If you block the right one, things get better. So he tried Prazosin, which is a blocker of the alpha receptor, the alpha 1 receptor. And the first person who tried it, he had severe replicative, like the same trauma over and over and over nightmares for many decades since Vietnam, and within 2 weeks they were gone. And this was shocking. He thought this had to be a fluke. Somebody else in the group tried it, because once somebody said it was great, multiple people want to try it. And for a significant number of people, it was just this magical transformation. So he gradually went from case reports, writing this up, to case series, to open label trials, to a number of randomized controlled trials. Open label and randomized controlled trials were done in veterans and civilians. He and Dr. Peskin have a close association with one of the predominantly Jewish retirement and assisted living centers here, and they work with a lot of Holocaust victims there. And so they had a trial in that population. And the randomized control trials, there were several of them in different populations. The last one was actually, before this paper, was done at Joint Base Lewis McChord in active duty soldiers, and it was actually stopped early. It was supposed to be about twice as large as it ended up being. It was stopped early by the Medical Monitoring Board, which in the interim analysis said the results were so positive it was unethical to continue to have a placebo group. They made them shut down the trial the day they did the analysis and put everybody on active treatment. So when they we're going to do another larger trial, you can see why they felt very optimistic that they knew what the results were going to be. And one thing I think is interesting about this story is that it was done entirely through academic funding. So none of this is pharma funded. And because Prazosin is a cheap, generic medication that's already available, it has a low safety, pretty benign safety profile. it was easy to do this research on academic funding. But to do a large multi-site study takes a lot of money. So it's very hard to get sort of an NIH grant or a standard R01 size grant to
Mhm.
do a multi-site clinical trial. And so the way that this is done, besides pharma funding, the VA has a cooperative studies program where you can apply, and that if you were accepted, the team there works with you to develop the actual implementation, and then they expand your clinical trial to a number of sites throughout the VA. So this is what they did. They applied for this program, and they did this multi-site randomized controlled trial of Prazosin for PTSD. So I feel that my notes are all
So
forget the order of what I was going to say.
I
Yeah,
personally did not know all that. So I assume a lot of other people actually don't know, unless I'm just
good,
like,
good,
yeah, and that was really interesting. So thanks.
good. Yes. Yeah, I'm cutting out all the hilarious stories Murray Raskin tells from some of this, but um, so so this trial is really supposed to be the capstone, like the finally definitive proof that Prazosin works, and nobody will have to test it again. Thank goodness. And so the results were stunningly negative. So we'll get to the details later, but the basic result of the study is they did the same sort of structure of clinical trial they'd done in all these smaller trials, which some of which were done by Dr. Raskin and our group, some of which were done other places in the world. One was done in Iran. There were some done by totally independent groups, and all have been positive. And then this one, it's just completely flat. So the question is why? What happened? What does it mean? And where do we go from here? So my goals for this discussion were for folks to walk away being able to, number one, describe what the trial did and did not find. Two, have a formed opinion on how much it should affect your willingness to prescribe Prazosin for PTSD. That doesn't have to be my opinion. I'll be clear what my own biases are. So definitely form your own. And then three, have a generalizable template in your head for how to think about what do we make of negative trials in general, because I think this is a pretty good example. So to achieve this, we'll go through who did the trial and their disclosures, and I'll add my disclosures in there, what they did, what the results are, and then a variety of explanations that have been put forward about what it all means. And then also feel free to ask questions now or send questions later. I will talk about Prazosin and PTSD endlessly if given the chance. All right, so who did the trial? So Dr. Raskin and Dr. Peskin, I told you their background, geriatric psychiatrists. This is Dr. Raskin's baby. You know, he spent 25 years of his life on this treatment and cares about it passionately. He's somebody who's very devoted to patient care, and when something seemed like it was making a real difference, he was really committed to it. The rest of the authors are a mix. Many of them are staff that have worked in all of these trials here. Some are collaborators at other sites, and then some of them are co-op study, sort of the VA cooperative studies infrastructure folks, so biostatisticians and clinical trialists who are part of that program who are assigned to this study. So that's the mix of the authors. So the people implementing most of it were strong fans of Prazosin and strongly wanted it to succeed. And the biostatisticians and clinical trialists, you know, their job is to be objective. But I don't think anybody had anything but hope for it to go. And the analysis plan is pre-specified in a study like this. So it's like the code is written, it is entirely set in advance, and then it's implemented by the biostatistician co-op program. So I should also mention my biases or disclosures. So Dr. Raskin and Dr. Peskin are both close mentors of mine. I collaborate with them regularly. About half the people in the author lists for this paper are people that I either work closely with or have regular contact with. And I also do Prazosin clinical trials. So I have a number of clinical trials I work on currently. The majority of them involve Prazosin, often for PTSD. So I'm clearly motivated to disbelieve these results, and you should totally be aware of that bias all the way through.
Okay.
All right. So what happened in the paper? What did people do? So they recruited 304 veterans with combat PTSD who were willing to take part in a 26-week randomized placebo-controlled trial. And I think one of the fundamental questions about what happened with this clinical trial is how these people were selected and who they ended up being. So I think the two questions that people reading this paper probably want to ask are, number one, how did this group end up being different from previous clinical trials? And is there any possible explanation of why the results were so different in that? And secondly, does this match your clinical population? So if you treat people with PTSD, when we go through this sort of inclusion-exclusion criteria and who these folks ended up being, is this matching who you actually take care of? So the inclusion criteria were pretty basic. Number one, you had to have combat trauma, and they were very specific about this. So it had to be a criterion A, like meets the classic criterion A of the DSM diagnosis of PTSD. This is all DSM-4. It had to have happened in a combat zone, so by the sort of military standard definitions, and it had to have been sort of a combat experiences trauma. So MST, military sexual trauma, for example, would not actually count as part of this. They were really going for classic bombs blowing up, people shooting, I killed somebody, I watched somebody die, classic combat trauma. You had to meet criteria for PTSD currently. It couldn't be you met full criteria 6 months ago and you're they're decreased, but you still have residual nightmares. You have to meet full criteria currently. The CAPS is the clinician-administered PTSD scale. So it's like our formal research assessment tool. And it has a scale, and you had to have at least a 50. So that's moderate to severe PTSD. And for the nightmare item, you had to have at least a 5 out of a scale that goes from 0 to 8. And these had to be recalled nightmares. They couldn't be, my wife says I wake up thrashing and kicking and yelling about deployment. You have to be able to remember the content, and it has to be trauma related. Exclusion criteria, any previous adequate trial prazosin, you've taken trazodone in the past 2 weeks, and that's really because trazodone has a priapism risk. Prazosin has a priapism risk also, although it's lower, and people are afraid the combination would be dangerous. Substance dependence in the past 3 months was exclusionary. Abuse was not. That matters, and we'll come back to it. Diagnosis of sleep apnea that's untreated. So if you've never been tested, that's fine, but if you've actually had a diagnosis and you're not receiving appropriate treatment, then you're excluded. And then in the past 4 weeks, your mental health treatment has to have been stable, both medication and psychotherapy. And at no point in that 4 weeks you've had any EBP, evidence-based psychotherapy for PTSD. So primarily it means no prolonged exposure, no cognitive processing therapy, and no EMDR. And finally, you were excluded if you had psychosocial instability. And what that was not spelled out. Traditionally in these trials, what we did before this and what I'm sort of used to is if somebody's safe for outpatient care, we will likely consider them for the trial. But something that was happening right during the formation of this trial was veteran suicide was becoming a political hot button issue, and the VA was very concerned about the risk of suicides in the studies. So this was a requirement from the co-op study logistics group that said we had to exclude anybody with psychosocial instability. Normally our trials have something that looks roughly like my clinical population, where a significant fraction of people have significant alcohol use and are in the middle of, homelessness crisis, losing their job. All of that was excluded. The population was recruited 2010 to 2012. There's screened 413 people to get 304. The main losses were about 30-ish for not suitable for clinician discretion, so mostly that's going to be the psychosocial instability part, or didn't meet criteria for PTSD on formal assessment, which is also around 30. And then they had folks spend 26 weeks in a trial. So this is a 6-month trial. All of the previous prazosin trials were more 10 to 15 weeks, sometimes 6 to 15 weeks. This was another request from the co-op group, which really wanted this to be the definitive, what happens over time? Does it continue to work for the entire period? That also meant if you referred your patient to this trial, you were signing them up for potentially 6 months of placebo. The primary endpoints were actually measured at 10 weeks, but they also followed that long. So they had great retention. They managed to keep 94% of people for at least one visit after the 6-week mark. So they got some outcomes data, which is great. And then about 90% at week 10 for their primary outcomes, which is actually phenomenal for a clinical trial. And what you'd imagine to be an acute population, and then about 80% or just over at 26 weeks. Um, I can't keep my clinic population for 6 months that stable.
Hmm.
So also interesting. So who did this population end up being? So it ended up being 98% male, which makes sense given the this has to be combat trauma. The average
Yeah.
age was over 50, so this was not primarily post 9/11 vets. In fact, only about a quarter were post 9/11 vets. About less than half had comorbid depression, which is a little bit noticeable to me. Less than a third had comorbid other anxiety disorders, which also stands out to me. I would say that's somewhat not representative of my clinical population. Over 75% were on another antidepressant throughout the trial. About 10% were on benzodiazepines. 80% were service-connected for PTSD, meaning they get long-term disability payments from the VA for their PTSD symptoms. And the most amazing part to me is of the entire 300 plus veterans in the group, only 4 individuals met criteria for alcohol abuse and 2 for cannabis abuse. And that was it. So like 1% and less than 1%. So doesn't match previous studies, and it does not match my clinical population, but it may match other people's more closely. All right. So I was going to move on to the primary outcomes and results. I don't know if it's helpful to stop for questions.
I don't see any questions quite yet, so we're
Okay,
good. Yeah. If
great.
anybody does have a question, feel free to post.
I can see them on the screen. It's like magic. It's fascinating. I clearly don't do Facebook videos. It's all new technology to me. All right, so the primary outcomes, they had 3, and rather than saying you have to adjust for multiple comparisons, their statistical plan was that they expect Prazosin to significantly outperform placebo on all 3 was the expectation, which matches the previous studies. So there are 3 primary outcomes assessed at 10 weeks were the CAPS B2 item, which is just specifically the nightmare item. The PSQI, the Pittsburgh Sleep Quality Index, which is just it's like a whole bunch of questions about sleep quality for all possible causes, add them all up. So it's a really broad net for sleep quality. And the CGIC, the Clinical Global Impressions of Change, which is really a rater, looks at how things are now and looks at how things were then and says how much are things improved on a 1 to 7 scale, with 4 being no change. Things lower than 4 are improvement of varying degrees, and things higher than 4 are worsening. All right, so the result was flatly negative across the board. So none of the 3 primary endpoints were superior for Prazosin. There are trivially larger drops in 2 of the 3 primary outcome measures. So numerically, the Prazosin group was better than the placebo group, but not statistically significantly and not clinically significantly at all. Like this is about as negative a study as you can find. The secondary outcomes were pretty much evenly distributed between like trivially better in the Prazosin group versus trivially better in the placebo group. The only significant difference at all was new or worsening suicidal ideation was significantly lower in the Prazosin group than the placebo group, which, there were a lot of things tested. So I don't think that means a whole lot other than the paper that got a bunch of attention recently saying there was more suicidal ideation in the 26 completers trial. So that wasn't matched here, but nothing was better truly in any of the planned outcomes for Prazosin. And nothing was worse. It was just totally flat. In fact, it was so flat that the people who ran the study went back and tracked down the sourcing of the drug to see if it was even the right medication, because people were so shocked. They thought maybe it had actually been a related drug that didn't cross the blood-brain barrier, and that could explain it. But mass spec says no, it was indeed Prazosin. All right. So other things that are notable about the results is that it's not really that there was a large placebo effect. So a lot of times when you have a negative trial, when you didn't expect it, it's because the placebo effect is so high that it's hard to pass it. But that really wasn't true here. So that the total CAPS score went from about 80 to 70 in the placebo group. That's actually lower than most of our previous trials. So the trial I mentioned that was shut down early for being too positive to be allowed to continue, it had gone from 80 to 65 in the 85 to 65 in the placebo group, but it was an over 30-point drop in the CAPS and the Prazosin. So it was actually a lower placebo effect than other studies, just a dramatically smaller Prazosin effect as well. All right, trying to think if there's anything I missed out from the results, but that's pretty much it. So the question is, what does this mean? So I think there's basically been three basic takes. So one is it was a negative trial, Prazosin didn't work, we're done. Another is the idea that it was a failed trial. So, people don't use clinical trial terminology really consistently or precisely often. But in a very technical sense, a failed trial means the trial didn't actually measure what it was supposed to and is generally applied to a trial where you have something that's clearly been documented to be effective in other studies, but somehow was negative in the study. So for example, I was reading the treatment guidelines for bipolar disorder last week, and they had a couple little box sections on why do we recommend Depakote for maintenance therapy in bipolar 1, given that the only actual significant RCT of Depakote for maintenance therapy in bipolar 1 was negative. And they said, well, because it was actually a failed trial, because in that trial, and it's the only one of Depakote we have, Depakote and lithium and placebo were all done, and lithium also failed to beat placebo. So it was a failed trial, not a negative trial. Something just went wrong with it. We throw out the data and say we just don't know. And there's enough other hints that Depakote works, so let's call it fine. In that same paper, for example, lithium even, there was another little box on lithium saying, why do we recommend lithium for bipolar depression, given that, again, the only trial we have that's an actual significant RCT of lithium for bipolar depression was negative. And they say, again, there's other indications. We all know it works. It's been used for so long. Nobody's ever going to do another trial. We don't know what happened to that trial. It was just a failed trial. Failed trials are common, especially in recent context. So as sort of in parallel with the placebo group going up in our research over the decades, failed versus negative trials have gone up also. And they're very common, especially in the co-op studies program. So the VA cooperative studies, for example, had a trial of a large multi-site RCT of sertraline for PTSD, which is totally negative, of trauma-focused psychotherapy for PTSD, totally negative. Naltrexone for alcohol use disorder was completely negative. Depot risperidone for schizophrenia was totally negative. As far as I know, every trial of any mental health intervention done through the cooperative studies has actually had a negative result. I don't think they've had a single positive result. So then that leads us to this question: is this a negative trial, and we should maybe reconsider using Prazosin? Is it a failed trial? If there wasn't a positive control, how do we know? So a third take is that many treatments work for some people and not for others. And depending on which study population you recruit, you can have a totally different result. So our interpretation of the paper here, so mine and with slight details, I think this is the sort of common understanding in our highly motivated to continue to believe in this medication group, is that that's what's happened here, right? That when we look at who ended up enrolled, it did not match who had been enrolled in our previous trials, and that actually makes sense. So at one point I was running a randomized controlled trial of Prazosin versus placebo, and people, it was not to treat PTSD, but people with PTSD were eligible, and it was actually only 12 weeks long. I didn't refer a single person from my own clinic to my own study because I can't refer somebody to 12 weeks of placebo. Like, nobody I know would that be a reasonable option, given that, as was the case during this study, Prazosin is widely available. I can just prescribe it on the spot, right? So our sense is that anybody who actually had acute urgent need, Prazosin had been widely available throughout the VA. It was well known. Everybody at all these medical centers that participated in the trial, the psychiatrists there had been using it for years. And anybody who came in the door who they already knew, like, had been a good candidate, the 6-month placebo group. And then we screened out anybody with psychosocial instability on top of it. So that's our best take. There's lots of other thoughts, including was it having to do with the sleep apnea? Was it, or is it just that, it doesn't actually work? Some of the spin-offs, and this is mentioned in the paper, have been, how do we actually pick out up front who's going to be an appropriate candidate? And so Dr. Raskin has a follow-up paper which I'm on, but as a late author, looking at blood pressure, predicting who's going to respond and who's not. So that is all. I can't see a clock from where I'm at, so I have no idea how long it is or what time it is.
You're fine.
But I don't know if there's questions or thoughts.
Yeah, if anybody has any questions, feel free to post. I personally had a question.
Mhm.
I think you did. Why do you have any idea of why they only focused on combat related trauma for the nightmares and not other types?
Yeah, so the thinking, and I don't necessarily have exactly the same take. So I'll tell you my take and the take when this was being formulated. So the thought is that there are clearly different types of PTSD, and that combat PTSD is fundamentally different than a lot of um, civilian trauma. So, and I think that's clearly a relevant point. So, the way PTSD to me looks in somebody with sort of classic several deployments, they have 6 months at a time of sort of sustained vigilance with sleep deprivation, punctuated by often multiple acute traumatic events, is just a completely different thing than an adult with single incident civilian trauma, where something specific happened at a single point in time, but it wasn't on this backdrop of prolonged vigilance, often not against all this, means this sleep deprivation and deployment is profound. And then you have more support before and after. So I think there is a difference. The sense of the people putting the trial together, which was before I joined the group, but was that combat trauma is sort of the most pure example of this, and that MST or motor vehicle accident that happened while you were deployed to a combat zone are just fundamentally different. So they wanted to get as pure
Okay.
samples, they thought.
Okay, I did not know that. Okay, there are a couple of questions. One is about whether the data, or what is the data that you were referring to about blood pressure and responsiveness to prazosin?
Yeah.
That was the first question.
So yes, and this is like part of the basis of some of my current clinical trials. So I'm totally, again, like have a stake in this, but I think it's really cool too. So the thought is that if there's different types of PTSD, and some people have PTSD that's driven by increased signaling through the noradrenaline alpha-1 receptor, the one that prazosin blocks, and that's what's driving their PTSD symptoms. And then other people have some other pathophysiology, but it's not that one, and so prazosin doesn't work for them. We want to sort out who has this increased alpha-1 signaling that prazosin is going to work for, and who has something else and prazosin isn't going to work for them. So the alpha-1 receptor is plenty of other places in your body, and one thing it does is it actually constricts your blood vessels to keep your blood pressure up after you stand up. So 2 minutes after standing, if you take classic orthostatic vital signs, you have you seated, and then 2 minutes after standing, you take your systolic blood pressure, and you compare the two. The way you keep from having a drop in that standing systolic is by using this alpha-1 receptor. So the thought was if there's increased signaling, you would have actually an overshoot in this compensatory mechanism. So instead of having a maintained blood pressure or even a slightly lower blood pressure, your blood pressure would actually go up after standing. So we went and did a post hoc analysis of the active duty soldier study that was stopped early, that was much more positive. And it was a striking finding. So overwhelmingly, the entire result came from the individuals who had a high normal standing systolic blood pressure, individuals who had a normal or low blood pressure on that standing measurement looked like placebo. The caveat to that is these were overwhelmingly young, healthy men, and blood pressure regulation is different in women, it's different in older individuals, and it's different if you have medical comorbidities. So I don't think that finding necessarily generalizes, but it was a pretty clear, consistent idea that we might be able to tease apart who has this type of PTSD versus who has that other type that isn't going to respond.
Okay. Go ahead. I didn't mean to cut you off.
Oh no, I get confused by the time. Like I do get questions periodically from people saying, does that mean I shouldn't use it in this like young woman with very low blood pressure? And my experience is, no, it's totally fine. That it really is that there's a huge sex effect in regulation of blood pressure. And I do not see this pattern at all in women. It's also relatively easy just to try. So given that we don't really know how generalizable this result is at all or what the limitations are, I don't usually use it as a reason not to try it. But I'm much more likely to really try to get somebody to at least give it a shot if they have this really classic like overshoot pattern in their blood pressure.
Okay. So I think you then answered this question, but you mentioned about blood pressure. So what is the limitation of blood pressure? And then the next question, does prazosin not work as well in nightmares associated with non-combat related trauma?
So in my experience, it works very similarly. So I would say that the other groups I have particular experience with having very similar patterns that's not combat related is so refugee populations. I I've seen I feel like it's very similar to combat trauma.
Hmm.
Honestly, you have these sustained periods of sustained vigilance with punctuated individual traumas. Clinically, it looks similar, and prazosin seems to work great. In my experience. And then childhood trauma, often if people have, a prolonged period of um, instability and threat with acute traumas on top of it, in my experience, that has looked very similar, that it tends to have the same pattern. Um, the biggest difference I see for which nightmares respond and which don't is really the descriptor. So the most classic pattern is either a replicative trauma nightmare where it's like a video of that same thing. That's less true for childhood traumas. Those are more abstract for everybody because the memory system probably was working differently, presumably. But especially if it's a replicative nightmare, if people wake up with a startle sweat, one of my common questions is, did you have to change your clothes or the bed sheets? And often people say yes. Heartbeat up, breathing fast, like there's no chance they're going back to wake. They're going to be awake for an hour or two, or they're up for the night. That tends to work. Also, a whole lot of movement and yelling during sleep seems to be associated also. So there's my sleepage is an active duty sleep doc. She's just left active duty service and started an academic research group, but he's tried to coin this idea of there being a separate trauma-associated sleep disorder where you may not meet full criteria for PTSD, but you have so much movement during sleep it looks like RIM behavior disorder, but it's actually associated with the trauma and it responds to prazosin, not to benzodiazepines. So a whole lot of movement like that tends to be associated with the prazosin working as well, even if you don't have any recalled memory.
Okay. Wow. I feel like I learned a lot during this. Thank you so much. I don't see any other questions. If anybody has questions that come up over the next 24 hours, feel free to post them and we'll try to get Dr. Hendrickson back to this. But thank you so much. That was really informative and really interesting. Do you think that the MOC people put this article in as an example of a failed trial, or do you think that do you have any thoughts
So
on
that's a
that?
really good question.
Mm-hmm.
So I do know so I don't think Murray has ever hoped so desperately that the New England Journal would reject a paper.
Mm-hmm.
This paper broke his heart. But one thing that was very interesting going through the submission process there is that the main reviews that they kept coming back with, and it went through a gazillion rounds of revisions,
Mm-hmm.
but repeatedly the reviewers were saying, well, what about this factor that could explain that it's actually a failed trial? Or what about this factor? Maybe this is the reason that, it didn't
Mm-hmm.
replicate the results, but it's all still, so it was a very consistent response
Mm-hmm.
from those folks that we think there was something wrong with the trial design and we want to expand the space used to talk about that. But
Okay.
yeah.
I was just curious. All right. Well,
Yeah.
thank you. And thanks everyone for your participation. And we'll be back on Wednesday night with one of my colleagues in my department on an ethical women's mental health topic. So it should be interesting. And yeah, see you guys on Wednesday. Thanks again.
Thank you.
Take care.
Thanks for
Bye.
listening.
Yeah, thank you.
Bye.
Bye.